Thanks everyone for joining us for our webinar this afternoon on a virtual fee code update, navigating the updated virtual fee codes. My name is Brad Baylor. I'm a family physician in Sylvan Lake. I'm also the medical director for the AMA Accelerating Change Transformation team. Our two main speakers today will be Dr. Heidi Fell, who's chair of the AMA Informatics Committee and AMA representative on Virtual Care Working Group, and Norma Shipley from Health Economics at the Alberta Medical Association. We'll also be joined by some additional panel speakers later in the session when we open a question and answer period at the end of the presentation. Next slide, please. Please note that we are live recording the webinar. By participating, you understand and consent to the webinar being made publicly available via a link on the AMA website for an undetermined length of time. Participants may choose to ask questions anonymously in the Q&A. Please use the Q&A to ask your questions. We will be prioritizing questions based on a combination of upvotes and balancing amongst different topics in different sessions. These details will not be saved during the recording. The Alberta Medical Association acknowledges that we are located on Treaty 6, 7, and 8 territories, traditional lands of diverse Indigenous peoples, including the Cree, Métis, Nakota Sioux, Iroquois, Dene, Inuit, Blackfoot Confederacy, the Tsina First Nation, the Stoney Nakoda, and many others whose histories, languages, and cultures continue to influence our vibrant community. We respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our communities. Before we get started, I'd like to pass things over to Dr. Michelle Warren, President, AMA, for a welcome.
Hi, everybody, and thanks for making time to join us today. I'm sure that, like me, you were relieved to finally see a joint announcement from the AMA and the government on December 30th about the new virtual care codes. These codes were a long time coming, and a lot of work was done trying to bring them forward. It started after March of 2020 when the tentative agreement was not ratified. But we recognized that primary care and community care were really struggling with COVID and the impact that it had. So there was a working group included Alberta Health Services, the College, Physicians and Surgeons of Alberta, and the Alberta Medical Association. And they were tasked with looking at some changes to the virtual care codes to help stabilize things in the community, as well as some longer term considerations about virtual care and its role going forward. As you know, the AMA has been advocating for changes to the virtual care fee schedule in general to make providing virtual care more financially sustainable. I think these changes that we received does demonstrate some progress, but more work is definitely required because there's a number of other issues that have been identified that are still needing to be done. And so this is just at least a step in the right direction. That having been said, I know many of you have questions and need some guidance in terms of how to best use and optimize these virtual care codes. I'm looking forward to learning more with you all today. And with that, I'm going to turn it back over to Dr. Baylor.
Thanks very much. Our agenda is pretty simple for the day. We're going to spend some time talking about the policy background leading up to these changes. We'll be discussing the virtual care code changes themselves, including some examples that demonstrate how they are to be used. And then we're leaving hopefully 20 minutes at the end for question and answer as already discussed. And so next I'm going to hand it over to Dr. Fell to speak a little bit about the policy background that led to these changes.
Hello, everybody. We could go to the next slide, please. So this is a summary of some of the advocacy that the AMA has been working on virtual care during the pandemic. As you can see, we've been doing numerous activities and have tried numerous times to address various aspects of virtual care codes right since the first day that they were implemented. Some highlights of this are that through March and June of 2020, we were advocating for income stabilization and virtual code to the Pandemic Supports Working Group. In May of 2020, the work of the Health Economics Group paid some dividend in that they were able to add allied health referrals to psychiatry, virtual consultation, and chronic pain and palliative care were added. In June, the virtual codes were made permanent, and I point out that that's something that other provinces don't have yet. We will have permanent access to virtual codes. And we also started working on a draft concept paper, which was then consulted to all sections and worked with Alberta Health on that. Unfortunately, those conversations didn't proceed very far because of various issues at the time. We did present to the Physician Compensation Advisory Committee in February of 2021, and that was a more general presentation that included a lot more things than what you'll see in the later discussions. In the end of May was the first meeting of the Virtual Care Working Group that produced the changes that you've seen the bulletin from. We initially took a proposal to the steering committee, which included Alberta Health, AHS, CPSA, and the AMA in August. That recommendation was not accepted, and they asked for further revisions to it. And that work was done and presented at the end of November. Subsequently went to PCAC, and then went through some process after that between Michelle and Mike and the minister as well. And then you saw the bulletin issued on January 12th after the announcement was made on December 30th. So this is just an example of how complicated it was to actually get to this point. And just a reminder that all of this was done in the absence of an agreement. So there were some significant limitations that we had on the processes and our ability to consult through these processes that really affected how we could do things. So if we go to the next slide, please. The working group process was confidential and did not allow consultation with sections during it. So those were challenges that we were presented with. However, we were fortunate in that this was a step forward and that Alberta Health was willing to discuss this with us at all, and that we did have some basis for collaboration within the working group. Now, because there was not an agreement, and in the end, Alberta Health gets to make all of the decisions, you'll notice that the scope of what came out of here is narrower than what we might have liked. And that is because we needed to have a place to start with Alberta Health, and Alberta Health had to be willing to consider the idea before we could actually explore it further. There were some things, for example, that we raised, but that there really was no starting place to have a discussion with Alberta Health outside of an agreement on those items. So they had to be left aside for the time being. That does not mean that our consultations are finished. And there are still, especially going into negotiations, there are now potentially new opportunities to continue working on the virtual care codes. And so what you see now is, I would think of as the beginning of changes, I certainly hope, rather than the end of changes. Okay. But what came out of the initial working group that went to steering committee were the 5 items you see there. So indirect care, age modifier, limited complex modifiers, 0819 CW, reducing that to be the same as in person, which is 8 minutes or 7.5 minutes versus a full 15 minutes, and reducing the 10-minute requirement for some of the virtual codes to, again, a greater portion of 15 minutes. All of this should be backed up by evaluation as to what this is doing within the system. So is it shifting things inappropriately? Is it affecting how many visits go to emerge? You know, all of those sorts of things. What's it doing to the fee schedule overall? Are different sections getting more money versus less money? You know, how is it changing the care landscape? So this was taken to steering committee in August, and it was not accepted, and the response was that we needed to further refine it, prioritize it, and provide a logic model for it. So that work went on after that, and in November we presented a revised proposal to them, and you can see it includes the indirect care and the single complex modifier as the highest priority items that needed to be done immediately. The mental health code 0819CW was put as a moderate priority, and evaluation still needs to occur. And so this was approved by the steering committee to go forward to PCAC. PCAC did their thing, which, as we know, is a confidential process. And then the output came and went to the minister and went through some discussions with Mike and Michelle. And then the announcement was made on December 30th. And then you saw the bulletin come out on January 12th. Now, I would acknowledge that there are limitations to what we've achieved here. There are still gaps. Mental health is a significant one. These codes still do not deal well with complex situations for numerous specialties. And so there's a lot of work that we still need to do. But in the absence of agreement, this was an important step forward that did help provide some practice sustainability for sections like family medicine, where the virtual codes were creating a significant difficulty in actually keeping practices open. Now, family medicine is by far not the only specialty affected, but it was the one that had become very public in terms of the lack of ability of anybody in Lethbridge to get a family doctor, for example. So some of those things that had occurred in the primary care space gave us an opportunity to make some progress, not just for family medicine, but also for many, many other specialties. So thanks, Brad. I think I'll hand that back over to you or to Norma.
Yeah, I think we're going to hand it right to Norma, who's going to lead us through the changes in more detail.
Great, thanks very much, Dr. Fell. So the virtual care changes effective January 1, 2022. That's an important date to remember. What's new in there is essentially that physicians can include their same-day patient care management time to review any chart or diagnostics before seeing the patient, to coordinate care at the same day as they've seen that patient. So that could be confirming a referral with their medical office assistant, writing a referral letter, writing their consultation letter, organizing follow-up care, their charting, and then any writing of that consultation letter following that can be included both in the base time for your virtual visit and in any eligibility for modifier time. And we'll talk a bit more about that detail of how you do that in a couple of slides. Just a reminder again, this is a first step in having longer virtual care visits and consultations recognized in the schedule. And we do hope that there are more changes coming in the future. Could we go to the next slide, please? There are specific time and other requirements when you're thinking about those January 1 changes. Physician to patient direct contact time is part of that time accumulation. Now you can include your same day patient management time. The times for the basic visits are still the same. So 0301AD is still for your work that is less than 10 minutes on the date the patient is seen. 0303CV, which is like your 0303A, 0303FV, which is like your 0303F for select specialties, must be at least 10 minutes in order to claim that base code. And in addition, your 0308CV must also be at least 10 minutes. There still is the requirement to keep your record of the start and stop time of your direct patient contact time. And then separately, I would recommend that you document your indirect time, your patient care management time in the patient chart. So for that, I wouldn't say you have to keep your start and stop time of that in that, but do record start and stop time of your direct patient contact time, 10:02 to 14, and then your indirect time, 8 minutes, for example. Could we go to the next slide, please? So what premiums and modifiers are available? For family medicine, CMGP 01 is available for your 0303 CV. For 0303 CV and 0303 FB, other specialties will, in consistency with the 0303A and 0303F, have eligibility for the CMX V15 or V20 modifiers. And then the CMX C30 modifier is applied to the 0308 CV. There still is no business cost or rural remote northern payment associated with these virtual care codes. But one thing to consider is that they will not be part of that 50 per day maximum for urban and some locations. So you will not be counting these virtual care visits toward that 50 per day maximum. There still are limitations in terms of can you claim a virtual care and in-person visit for the patient on the same day. You can only claim one of those. So my recommendation is if you see a patient in person later on the same day that you've had a virtual visit, you include that virtual visit time in your in-person visit modifier time. All of that would then be time worked on the date you see the patient and can be incorporated in that. One of the things that Alberta Health has been very specific about in the virtual care wording is that your inclusive time may not include administrative tasks. So those would be things like clinic management, submitting and reviewing your claims. And that wording is quite specific, both in the existing codes and we think will remain in the new code changes. Next slide, please. For 0301 AD, again, it remains at 10 minutes direct and patient care management time. It can also be used to respond to patient-initiated email or electronic communications. I would ask you to make sure that you're being consistent with CPSA security requirements, so that's something to consider as you're thinking about using this code for that purpose. And remember that this code would include prescription renewal or a new prescription that you would send to the pharmacy related to that, and that the 0301 NM could only be claimed with this and any other virtual codes if the pharmacy initiates contact subsequent to that prescription receipt. Could we go to the next slide, please? So for using 0301 AD, if the physician has a 5-minute direct contact with a patient to monitor their very well-controlled chronic disease, and then spends 2 minutes time charting after the visit, that claim, even though it includes indirect or patient care management time, would be for an 0301 AD. If they spend 7 minutes time on the direct communication with the patient, and then 5 minutes talking to their MOA about scheduling follow-up appointments and coordinating care, that's when they could use an 0303 CV, but they would not yet be able to bill the time modifier because their total time is only 12 minutes. Can we go on to the next slide, please? Again, 0303 CV, that's like your virtual 0303A. Your time, including direct and patient care management time on the same day, needs to be 10 or more minutes. You need to make sure that your records include a limited assessment of the problem and advice you've given to the patient, as well as your start and stop time, and again, include a notation about your patient care management time as well. There are 3 different modifiers that will be applied to that code, and different specialties will have different abilities to use those modifiers. Could we go to the next slide, please? This slide is very detailed, but in essence, whichever of these modifiers you would use on your 0303A, you would use the same modifier with the same constraints for your 0303 CV. So family medicine, CMGP01, the listed community medicine, occupational medicine, infectious diseases, internal medicine groups would use CMXV15, and then any other specialty that is not family medicine or listed in the the CMXV15 modifier group would use CMXV20. There are differential time requirements. CMGP 01 and CMXV 15 each require at least 15 minutes of physician work related to that patient on that day, including your direct and patient care management time. CMXV 20 requires 20 minutes of that time. Could we go to the next slide, please? So as an example, to bill an 0303CV, if your time spent reviewing the patient chart and any recent diagnostics is 5 minutes on the day you see the patient, you spend 8 minutes directly with the patient by phone or video conference. And then after that, you're spending 8 minutes to arrange referral to an allied health practitioner, doing your charting, giving instructions to your office team about a follow-up visit. For a total time of 21 minutes, family medicine would claim 0303CV plus CMGP 01. If you are one of the specialties eligible for CMXV 15, you'd claim that modifier with your 03CV. And then the CMXV 20 specialists would use the CMXV 20 modifier. Make sure that you are attaching the modifier that you would normally use for 0303A, and you should be safe in that. Could we go to the next slide, please? For select specialties, and I've seen a couple of questions in the chat about why are only certain specialties eligible for the 0303FB. The reason for that is that follows the eligibility for 0303F, which is a specialist follow-up visit for a referred patient. Certain specialties have in the past organized to have that code available for them, and health economics team can, outside of this, provide more information if you are interested. That code requires 10 or more minutes of direct contact with the patient, plus same-day patient management time in order to be claimed. You're going to have a history of the problem, you're going to create your patient record, including start and stop times, and you're going to give some advice to the patient about their care and management of their condition. Again, it's not claimable on the same day as another virtual or in-person visit. For modifiers, and could we go to the next slide, please? Respectively, either CMXV 15 or V20 would be available. The specific groups: cardiology, endocrinology, hematology, infectious diseases, other internal medicine subspecialties, cardiology, and then pediatrics and selected pediatric subspecialties. Those groups are able to bill the CMXV 15 modifier when their same day total physician time is at least 15 minutes. Other specialties who also use the 0303FV would need to spend at least 20 minutes of patient care time, including their direct time with the patient on the date they were seen, in order to bill the CMXV 20 modifier. Could we go to the next slide, please? So as an example, if the physician spends 5 minutes earlier in the day reviewing previous diagnostics, and maybe this is someone who has a quite lengthy history, so their complex care has quite a bit of documentation, and then 15 minutes with the patient in follow-up to review their progress and their current status, and then 8 minutes later the same day charting, writing a referral letter to a subspecialist who had previously seen the patient. That total care time of 28 minutes would be billed as 0303CV plus the CMXV 15 modifier for some groups and V20 for others. Could we go to the next slide, please? For virtual consultations, so in the virtual consultation, the physician still, again, 10 minutes or more direct contact, plus same-day patient care management. The consultation requirements for referral from specific groups and return of a consultation letter after the patient has been seen and evaluated and a treatment plan developed still occur, as does the inclusion of this in the comprehensive visit group. So for 0308CB, it behaves in billing much like the 0308A and 0304A and AZ series, in that if you bill the 0308CB today, you may not bill another comprehensive visit or consultation for that patient within the next 345 days. For the work that you do on the date you see the patient, if that work is both including direct and same-day patient management time, 30 minutes or longer, then you would add that CMX C30 modifier. Could we go to the next slide, please? As an example, if the physician spends time reviewing the referral letter and looking at diagnostics on net care of 5 minutes, then has a 20-minute virtual visit with the patient and perhaps their legal guardian, spends an additional 12 minutes later that evening charting and writing the consultation letter back to the referring physician, their total time in that case is about 37 minutes, and they would claim the 0308CV plus CMX C30. Could we go to the next slide, please? There have been a lot of questions from physicians about submitting their claims and when Alberta Health is going to complete that system programming in order to allow you to submit those modifiers. They are, I know, working hard on that system programming, but it's not yet complete, and they will let us know, and you know, when those modifiers can be submitted. We don't have an exact timeline for that yet, but in the interim, one option is to submit your claim for the base code and then be aware of those claims so you can submit your modifier later on. In that case, important to make sure you have that documentation of both your direct patient contact time and your patient care management time on the date they were seen. The other option is to hold your claims until that system change is in place and then submit your claim for both the base visit or consultation and the modifier. Again, we know that that is not a perfect solution, and we do know that Alberta Health is working on those changes. Everyone will let you know what those status is as soon as we know. Could we go to the next slide, please? If you have questions or comments, so questions about payment policies could be directed to Alan Florzone, and just so people know, these slides will be available to you after the presentation, so you'll have these addresses. Questions about billing, again, email the billing advice team. The people that look after that are very well versed in the fee schedule, and we'll make sure you get correct answers for that. If you have questions about emails about AMA strategic direction, you can direct those to Dr. Warren at her AMA email account, and we will all be assisting her in responding to that. If you have questions about integrating virtual care and how to manage virtual care in your practice, the ACT team has huge experience in that, and they are a great resource for you in working in your practice and how to integrate that virtual care into your normal practice day. Could we have the next slide, please? All right, I'll hand it back to Dr. Baylor for the polling.
Thanks very much, Norma, for all that explanation. Before we get into our question and answer period, we just wanted to take the time to ask a couple poll questions of the participants. So poll question number 1 is, aside from financial considerations in your practice, what are the top 2 barriers to virtual care that currently exist for you? So can we put up the poll, please? And we'll just leave the poll open for a few minutes for people to vote. The intent is to use this information actually to inform future webinars and content. The second question also in the poll is, would you be interested in participating in a peer-to-peer session to work through some of these issues and ideas around virtual care? So please take time to answer both of those questions, and we'll leave the poll open for a few more seconds. So I'll let whoever is managing the poll close it down if they think they've had adequate time to answer. thanks to all those who answered. We're going to take these considerations into the future, and it'll help inform future content for webinars and for the ACT team. So thanks very much. Okay, let's move to the next slide. So in addition to our speakers that have already been on the webinar today, we have Dr. Duncan McCubbin, Dr. Ewan Affleck, Dr. Craig Hodgson, Alan Florzone from the AMA, and other AMA health economics staff to help answer our questions and answers. And we're going to just start working through some of the questions that have been posed through the Q&A. And we'll start with one that's a bit of a hot topic, which is, what do you do with virtual codes if the patient is not in the province, or perhaps not even in the country, or as a physician, you're not in the province, or perhaps not in the country? And what are kind of rules and regulations around this, and the billing considerations around this? So I think Heidi's going to start with this one. And then we'll also have Darcy add in from the billing perspective.
Thanks, Brad. So this one comes in not so confusing, really confusing, and a ludicrous level for it. The part that's not so confusing is that the CMPA says you are okay to provide care as long as both you and the patient are in Canada. Okay, so that's the part that's not so confusing. The part that's partially confusing is the college regulation. So you as a physician are regulated by the CPSA within Alberta, and the CPSA says that you as an Alberta physician regulated in Alberta are okay to provide virtual care to patients across the province. However, the patients are regulated by the province in which they're physically located. So you have to check with the college where the patient is physically located to see if you can actually provide virtual care to that patient or not. So that's different for every single province. BC, for example, is more permissive. Other provinces are less permissive. Where it gets ludicrous is if the patient is, or you are out of the country, and so you really need to check in with the college and the CPSA before you contemplate doing, the CPSA and the CMPA before you contemplate doing that, to understand those implications. And where it's very confusing is on the billing piece. So for that, I'm going to hand it over to Darcy.
Hi. In terms of billing, if the patient is out of the province at the time of the call, the college does say, like as Heidi alluded to, that you have to have be licensed to practice in wherever that they are, with the patient is at the time of the service. In terms of billing, if you have an out-of-province patient with out-of-province coverage, you could bill the patient directly and give them a receipt, and then they could try and recover that cost from their home province. That's not an ideal situation, but unfortunately, that's the situation that we're in at the time in terms of billing. Alberta Health and the AMA have been advocating at the national level to have these changes made, but it does require national cooperation in terms of changing that medical reciprocal agreement. So unfortunately, that's the situation we're in at this time.
I guess I just add these medical reciprocal agreements are pretty archaic. They go back 20, 30 years or more. And so it does require that they're all bilateral agreements, and it does require sort of the provinces to cooperate and do that. And nobody wants, for example, a virtual walk-in clinic in one province servicing the rest of the country. So everybody's grappling with virtual care, all the rules around it, regulatory, etc. So I think it'll take a little while for them to sort that out before they sort the billing, like the reciprocal billing, and put in sensible rules around it. But in the meantime, as Darcy suggested, probably best to just, if you can bill the patient directly at Alberta rates, then they can seek payment or recovery of payment in their home province.
Okay, thanks everyone for those answers. Definitely a difficult topic when you lay in the billing and the regulatory factors, especially the differences between the provinces. So thanks everyone for answering that. Next question is around secure messaging and what code would be best to use for secure messaging. And then kind of in follow up to that question is, with secure messaging, what does it mean two-way communication or patient initiated contact? And Norma, do you want to take that one?
Sure, thanks very much. So this knowledge has sort of developed over time as we ask Alberta Health questions and get their responses. So in general, if the patient initiates contact by calling with a question or by emailing the physician in a secure environment, then the physician's answer, either by email or in that secure chat style environment, if that's available, is billable under 0301 AD. If the physician is contacting the patient because they've gotten information that means they need to advise the patient to change their medication, to make other adjustments in what they're doing related to their care, the 0305 JR for physician phone call to patient is the more appropriate code to use. We recognize that there are limitations on how many of that code you can bill, that's 14 per week, but that is a more appropriate code to claim for a physician-initiated contact with that patient.
And just building on that, Norma, in the question and answer, there was also just clarification around prescription refills. So a patient messages you for a prescription refill, or you get a request for a prescription refill, and what are the best codes to use in that scenario?
So I think, again, if the patient calls or asks for a prescription refill through secure messaging and you as the physician are responding to that message, then I would say you could let them know, I'm going to send your refill request to the pharmacy and please take this action. You'd need to give some sort of action advice to the patient in order to claim the 0301 AD for that. But you would not be able in that situation, because you're initiating the contact with the pharmacy, to bill the existing pharmacy communication code. That one could be claimed if the pharmacy initiates communication with you subsequent to getting your faxed or otherwise communicated prescription, and they have a question that is something that's claimable under that code. So it wouldn't be able to be claimed if, for example, you were sending a written prescription and they couldn't read your writing. It's really to clarify, to advise you of other drug interactions, because you might not be aware of all the prescriptions the patient has and so on.
Brad, could I add on to that one a little?
Yeah, I was going to ask you.
Yeah, thanks. So one of the things that has come up is, so first of all, on the refill front. So if you get a refill request from a pharmacy and you don't communicate with the patient, the appropriate request or billing code there is 0301NM, correct?
Heidi, that would only be for a very short-term renewal for that prescription.
Yes.
So
if a renewal, if a renewal should not have otherwise been provided otherwise, is how that text reads.
Yeah.
Okay, but yes, you wouldn't bill an 0301 AD for that because you had no contact with the patient at all.
Right.
If you had contact with the patient and it was a short contact, and it really shouldn't matter if it's by phone or by secure messaging, because you could use for a short contact, you could use the 0301 AD for either of those.
Correct.
However, if it turned into a longer conversation, more than 10 minutes, you could then use the 0303 CV code, but you could not also bill the 0301 NM code for that.
In general, I like to think about the 0301 NM as pharmacy-initiated contact with the physician. It's not for physician-initiated contact with the pharmacy.
Correct. Okay. And then we have further questions about the 0301 AD and physician-initiated things. And the question really, and so for phone calls, we do have the 0305 JR code available, but for messaging, we do not. And so I think we did have the communication and clarity from Alberta Health that does say, if you're in a family medicine context and you're working with a panel manager, for example, in a with a panel of patients with the pre-existing relationship, that it would be acceptable to bill those codes because it's a pre-existing relationship for screening or something like that. Correct?
So there were initial commentary issued by Alberta Health in collaboration with the AMA about panel management. They have not rescinded that, so that remains. The issue that I think we often hear is, what happens if I get a test result that needs action, or I need otherwise to, at my initiation, communicate with the patient? In that case, for phone calls, definitely 0305JR. If you're initiating electronic communication in a secure environment, there is the 0301S and T that are pre-existing codes. Again, they have maximums that can be claimed, but they are more appropriate for a physician-initiated communication outside of that panel management activity.
Yeah, this is an area of controversy because in my discussions with Alberta Health, they consider if it's follow-up of a test that was already patient-initiated because they came in for the visit to get the test. So this is an area of controversy, and I think something that we need to clarify further going forward. But suffice it to say, there is enough uncertainty that there's no clear requirement that you bill 0301S in many of those circumstances.
I would agree with you that there needs to be some clarity. We are, I think, sometimes getting inconsistent messaging from Alberta Health about those things. And so I think maybe, having everyone at that table to really confirm what those interpretations are would be very helpful.
The next one is, maybe for Heidi or Heidi and Alan, and it's really a policy question. I think there's some frustration in the Q&A around the fact that it really is CMGP 1, that you can bill as in only one call. And so the question is, what led to that decision? And is there any future action around that? And that really, I think, sits in that policy bundle, Heidi. So I'll give it to you.
Sure. So there was agreement that some complexity can be dealt with virtually. However, there was not consensus in the group that extensive complexity is appropriately dealt with virtually. And therefore, there was, we advocated as the AMA for additional units of complex modifier, but we could only obtain consensus among the group on one at this point in time. So that is something that we will have to continue to look at and work on through the negotiation process.
Yeah, and just to add what Dr. Fell said, our original proposal to the Physician Compensation Advisory Committee was for a very comprehensive set of virtual codes. So we said any service that can be provided virtually should be paid at virtual, or we should add a code and be paid at similar rates to in-person visits, sort of like they did in BC. So that didn't include just the CMGP 02 to 10 series, but also prolonged visits, should all the mental health series, group and family therapy. That was all in our original proposal. But of course, you gotta look at, what can you reasonably achieve in sort of stabilizing medicine in the immediate term sort of thing. And that, I think, was sort of the decision behind sort of to bring it down to what you can agree to sort of thing to get things going.
Thanks, Alan and Heidi. And so the next one that's come up a number of times is around 0819 CW or CX. And, when can you use those codes? What are the criteria around the codes? Can you bill multiple calls of those codes? Can you use indirect time on those codes? And so I don't know, Norma, if you want to start with that one. I think you're on mute still, Norma.
Great, thanks. I think that, we've all acknowledged that there's additional work to be done. The existing requirements for direct time only for 089 CW, 0819 CV, and 0819 CX remain. And so, unfortunately, the team that was discussing was unable to get Alberta Health to move from their perception of what is incorporated in the payment for those codes. So those still remain as direct patient contact time only. And I think that, I'll pass it over to Dr. Fell. She may have some other comments about some of those discussions and where we're headed for future commentary or conversations with Alberta Health.
Yeah, so mental health is a tricky area. First of all, I want to say that the concerns of mental health providers, including psychiatry and family physicians and generalists in mental health and pediatricians, et cetera, are completely valid. However, the system was not designed to, the part of the negotiations that I was involved in was not designed to fix any problems in existing code sets. It was only designed to deal with discrepancies between virtual and in person. And unfortunately, there's not consensus on some of these items as to whether indirect care should be added, whether indirect care is already compensated for within the codes, for example. And so this is an area that really needs further attention. You'll also notice that the 0819 CW code still requires a full 15 minutes for family physicians, whereas the in-person 0819G code only requires the greater portion of 15 minutes. So there are discrepancies across the map with respect to mental health care. And so it is an area that we need to continue to explore and examine. But some of those discrepancies go way back in history and substantially predate the virtual care. So might have to be part of a larger framework of agreement rather than specific discussions around virtual care.
And then, so for clarity, the indirect time, like charting time, referral time, the things that you spoke about in your presentation, Norma, which codes do they apply to for our members as of right now?
So right now, those indirect or patient care management time inclusions may only be applied to 0308 CV, 0303 FV, and 0303 CV. 0301 AD, again, less than 10 minutes of a combination of direct patient contact and patient care management time. But to add the modifiers, 0303 CV, FV, and 0308 CV are the codes that allow for patient care management time to be included.
Thanks so much, Norma. In addition to that, there were some questions around the caps, and I heard you say in your presentation that virtual codes may not apply to the 50 patient cap. And so if people are having issues with that or need clarity around that, I'm assuming they could message you guys through the email addresses you provided. But maybe just for clarity for everyone, you could tell us if that is the case.
That is the case. So if you are billing any of the virtual care codes 0301 AD, 0303 CV or FV, 0308 CV, 0819, CX, CW, or CV, those codes are not supposed to be included in your visit cap or maximums for that day. If you find that that's happening, or you think that that's happening, please do let us know so that we can talk to Alberta Health, make sure that their system is making those edit checks appropriately.
Thanks, Norm. And then the last question, and it's really a theme of questions, when there's family physicians who may be doing kind of specialist work, like family physician who might be working in a specialty clinic, maybe they're doing oncology, maybe they're doing, orthopedics, but they are, designated as a family physician. can they use the specialty modifier codes, or do they need to use the family physician modifier codes?
The fee schedule is sort of a rigid document, and it looks at your individual specialty designation to determine what fee codes and modifiers you're able to claim. So for example, if you, Dr. Baylor, are doing sort of sports medicine work and seeing patients referred to you, you would still be paid under your GP skill code for those referrals, whether that was in person or virtual using the 0308CB, and you still would use modifiers for any follow-up visits that were CMGP modifiers rather than the CMX modifiers.
Yeah, so there, the key there, I think, is that it's tied to your skill code in the billing system, not the work you're doing in terms of practice.
Correct.
There were also some questions about the second visit for WCB, and if you're doing WCB work virtually, but there's a second issue that emerges, is the 0301J still applicable in that circumstance? I think you're muted still, Norma.
For patients you're seeing virtually, you would use the 0303CV or 0301AD, depending on your time commitment for that second issue. You would bill your WCB care to WCB and your Alberta Health care to Alberta Health. One of the things that I'd really recommend is make sure you're very clear in your patient record of the time spent doing the work-related care and the time spent doing the insured service care.
And likewise, just in terms of tracking the CMGP codes, I heard you say earlier, if you want to track your direct care on the phone or virtually with the patient, but you also want to track or at least chart that indirect care time or amount of time in there somewhere as well. Is that correct?
Yes, I would highly recommend that, both for purposes of being able to submit your claims once those codes have been released, but also to make sure that you're covering off those documentation requirements that are currently so specific in those codes, and we think may continue as Alberta Health writes the specifics of those health service codes and releases them.
Thanks, Norma. Heidi, I just want to go back to the province question. So just in the simplest of circumstance, I'm a family physician and I'm in Alberta and I have a patient who's in BC or in Saskatchewan. What do I need to do to make sure that I can provide care? And what do I do on the billing side?
So on the CMPA side, you're covered as long as they're in Canada and you're in Canada. On the college side, if the patient's in BC, you need to read the college guidelines for BC, but I believe they're quite permissive, so you're probably okay. Saskatchewan, I believe, is quite different. And so you'll have to read and check that you're okay on the Saskatchewan side to care for that patient. I'm not sure that you are. From a billing perspective, if the patient has an out-of-province billing number, you will not be paid. So you need to bill that to the patient and give them a receipt so that they can see if they can recoup that from their government. If they have an Alberta number, technically you are required to both be in the province in order to bill. Now, if the patient is temporarily out of the province, how would Alberta Health know? And indeed, sometimes you may not know they are temporarily out of the province. So the bill may go through. However, it doesn't fit with the current billing guidelines. So in those cases, you're best off to bill the patient as well, and they may or may not be able to recoup the costs there. What that dials down to practically is that my reception has been starting to ask people where they are located, if there's any suspicion that they're not around. So if they're in college in BC, for example, and they've been explaining that except in rare, emergency type situations, I can't actually provide care for them that is covered. And so that's challenging and that's difficult, and that is very much less than ideal, but that is the current state of our system.
You want to ask?
I was going to ask Norma a question about that. Is there a pathway, Norma, to use the older set of codes, the 0305JR, 0301S, or 0301T in that circumstance? Because those don't explicitly say, both have to be in the province, while they still exist anyways. It is.
I think that is something that we would need to clarify with Alberta Health. We'd need to also consider some of the college requirements in that. I'd be reluctant to give a really definitive answer until we'd sought some clarification. And one of the challenges is we never want to give advice that will put physicians offside with Alberta Health. So that's one of the reasons we're quite cautious in what we say around this.
Yeah, thanks.
Well, thank you so much for all the panelists answering those difficult questions. And I know Health Economics is working hard continuously to try and get clarity on all these issues from Alberta Health, and then provide resources to the membership in terms of tips and tricks and frequently asked questions. So as more clarity or information becomes available, that'll be passed on to the members directly. But I think we've answered the majority of the questions that bubbled to the surface today. So I think we'll just take it to the last slide, please. Upcoming webinars. So we're contemplating peer learning and virtual care delivery. No date yet for that, so stay tuned. There is a webinar tonight, COVID Corner out of Calgary, talking about bringing clarity to some of the challenges around Omicron, and that's at 7 p.m. tonight. And if you're looking for previously recorded webinars, upcoming webinars, you can visit the AMA website at the address below. And with that, I think we'll bring our section to a close. Thank you for all the presenters. Thanks to all the panelists, and thanks to all of you that spent your time with us today to learn about the virtual codes. And we'll talk to all of you soon. Thanks.